The topic is atrial septal defect. Atrial septal defect is an opening in the atrial septum. It's an abnormal opening, and this allows the flow of blood between the atria. There's an ostium primum atrial septal defect, and there is an ostium secundum atrial septal defect, and then there is a sinus venosus atrial septal defect. And location-wise, the ostium primum atrial septal defect is low in the septum. The ostium secundum is around the region of fossa ovalis, and sinus venosus defect is around the upper part of the septum. With ostium primum atrial septal defect, there are often mitral valve abnormalities, and often a regurgitant mitral valve is associated with this condition. There is frequently anomalous drainage of pulmonary veins into the right atrium associated with a sinus venosus type of atrial septal defect. The Holtz-Oram syndrome is a hereditary disorder transmitted in a autosomal dominant fashion. In a secundum atrial septal defect and the forearm and the hand bony abnormalities occur together. In an ASD, folks often present with palpitations as a result of atrial arrhythmias and dyspnea on exertion, respiratory tract infections frequently, fatigue, and symptoms of right ventricular failure. Folks with small defects are generally asymptomatic, and in severe cases there is cyanosis and clubbing. But generally speaking, folks with ASD have prolonged symptom-free periods and are usually asymptomatic. There is a wide and fixed splitting of S2. There is a delay in the pulmonic valve closure as a result of increased flow through the right ventricle. And respiratory variation is almost absent in the splitting of S2. The systolic ejection murmur due to increase in the pulmonary blood flow. This murmur is heard in the pulmonic area. In a ostium primum defect, there is a pansystolic murmur as a result of mitral regurgitation heard at the apex. And then there could be presence of right ventricular impulse and presence of edema, neck vein distension, ascites. On the ECG, the findings related to ostium primum would involve the anterior fascicles of the left bundle producing a left anterior hemiblock, and ostium primum would be associated with left axis deviation, and also at times there is a right bundle branch block, and also there is a finding of prolongation of PR intervals. Ostium secundum findings would include right bundle branch block and right axis deviations, and sinus venosus defect would often include left deviation of the p-axis. On an X-ray, there would be cardiomegaly and enlargement of the right atrium and the ventricle, and increase in pulmonary vascularity. The pulmonary artery is large and the lung vessels large, and this is indicative of the left to right shunt, and the shunt vascularities as a result of increased pulmonary blood flow. And on the lateral view, the enlarged heart is in contact with the sternum, and often there is a slight bulge of the sternum forwards. And the enlarged right ventricle encroaches upon the retrosternal space. Cardiac catheterization, the diagnosis is confirmed. The pressures across the two atrium are equal, and there is a step up in the oxygen concentration in the right atrium as a result of shunting of the blood, which is highly oxygenated from the left atrium to the right atrium. And it helps confirm the diagnosis in surgical candidates, and also in situations where the echocardiography is not very clear. Also in situations where there is a significant elevation in the pulmonary artery pressures. The echocardiography with saline bubble contrast and Doppler flow studies are performed, and often to demonstrate the defect in the looking at the shunt, and transesophageal echocardiography has a higher sensitivity when looking at a sinus venosus defect. And treatment-wise, for folks with ASD, one needs to administer prophylactic therapy to prevent the atrial arrhythmias. And for folks who have a reverse shunting, as in Eisenmenger syndrome, where there is pulmonary hypertension with reverse shunting, under those circumstances, the risk of heart failure is increased, and therefore one needs to avoid surgery in such folks who have reverse shunting with pulmonary hypertension. And folks with ostium primum defect and having significant shunting, under those situations, such folks basically are indicated to have a surgical closure of the ASD, given that they don't have any significant pulmonary vascular disease. For ASD closure in children, a transcatheter closure is advocated, provided it's feasible.